I'm just preparing to leave my hotel room here in Winnipeg. It's minus 15 degrees outside and oh so dry. And I am excited, though, to venture out of my hotel to visit the Northern Connections Medical Center and learn more about how they've transformed the way that they approach care and redesigned their spaces and their service delivery to be much more welcoming, inclusive of people who are Indigenous and their very specific healthcare needs. So I'm looking forward to learning more about how they're supporting their Indigenous population and the Indigenous population living here in Winnipeg. All right, more soon. Hi, I'm Dr. Tara Kiran. I'm a family doctor and researcher who's passionate about building a stronger, more equitable primary care system in Canada. In 2022, I launched Our Care, a national initiative to co-create a blueprint for primary care together with patients and the public. Now, the people we spoke to were very clear. They felt every person in Canada deserved access to high-quality primary care. Care that's timely and ongoing, delivered in a culturally safe way from a team, where community supports are integrated, where patients have access to their own medical record, and where ultimately the system is accountable to the community it serves. Welcome to Primary Focus, a launching point for a national conversation we really need to have about the current primary care crisis in Canada and how we're going to solve it. On this podcast, I'm going to take you with me as I travel the world to tour different health systems and innovative clinics that have lessons we can learn to help us improve primary care here in Canada. Together, we'll visit the Netherlands, Costa Rica, Spain, Denmark, and places here in Canada to see what they're doing right and how we can use what's working for them to help improve our health system in Canada. Now, as we start on this journey, I want to set the context of where things are in Canada. A country that's founded on colonized Indigenous lands and where Indigenous people today have some of the worst health outcomes and poorest access to healthcare. I mean, there are huge gaps in life expectancy. For example, data from 2021 from BC notes that the average life expectancy for someone who was First Nations was 67 years, while the average for non-Indigenous BC residents was 82.5 years. That's a full 15-year difference in life expectancy. Shocking. Or consider that 1 in 5 Indigenous respondents to a 2024 StatsCan survey reported experiencing discrimination or racism in healthcare. Now that's depressing. If we really want to improve primary care in Canada, we need to improve care for people who are Indigenous. This means understanding and reckoning with our history of colonialism, the continued racism faced by Indigenous people, and understanding the unique considerations and approaches needed to make things right. That's why our second episode features a conversation I had with Dr. Mandy Buss. But before we go there, I want to take you to the clinic where she works, the Northern Connections Medical Center in Winnipeg, Manitoba.
Hi, Linda. Hi, Tara. Nice to meet you. Thanks so much for making time for me today.
Problem. Come on in. Kind of figure out what you want to know and who you want to talk to, and it's going to be fantastic.
Thank you so much also for agreeing to let me record it while... This is Linda Sindovich. She's the manager of the clinic.
Oversee the clinical team, more so the allied health and the administrative staff, the clinical support. So our history, so why we ended up here. So we at 425 Elgin.
Now, the day I visited Northern Connections, Mandy wasn't there, so Linda agreed to be my guide.
Do you want to give me a tour, actually?
Oh, yeah, we can certainly do that.
Maybe we can do a tour, and you can walk me through what we're seeing and how it helps to create the space that we're talking about.
I came to tour this clinic because what's become very clear to me in my research and my work with Our Care is that the fix to our primary care crisis is not going to be a one-size-fits-all solution, especially for patients who've experienced decades of trauma, racism, and erasure at the hands of our healthcare system.
Yeah, so you came in the front, the installation that you see.
I'm here to learn from Linda and her team about what they're doing to offer Indigenous patients the high quality of care they're known for. Northern Connections was established in 2010, and it was initially mandated to serve patients from the north coming into Winnipeg. And even today, about 80% of its clients are First Nations, Métis, or Inuit. Winnipeg is actually the Canadian city with the largest total population of urban and off-reserve Indigenous people. The clinic has 2 locations, and I visited the one at Seven Oaks General Hospital. It's a temporary location as they're doing renovations on their main clinic. When I walked in very many ways, the clinic looks just like any other hospital clinic. But then there's the art.
Make the space more inviting and less sterile. And so
Indigenous paintings, a handmade quilt, a large orange-themed art installation in honor of Truth and Reconciliation Day.
So actually one of our physicians, Dr. Donna Neufeld, created this for Truth and Reconciliation Day, and we just have felt that it should continue to be here. It's beautiful.
On their team, they have nurses, an occupational therapist, a physiotherapist, a dietitian, a pharmacist. So they're able to support complex needs and provide a lot of wraparound services.
We have a multidisciplinary team. So we have within our complement, besides physicians and nurses, we have social workers, including a position that we have funded through Indigenous Health Services. It's called a North-South Liaison. And so
what's wonderful to me is how Northern Connections is hitting one of the 6 Our Care standards. They're delivering care in a culturally safe way, specifically for people who are Indigenous.
We're also providing education to the medical residents so that they are starting their practice with understanding the importance of understanding past trauma and current trauma that individuals are facing in the healthcare system, as well as the importance of building relationships. So that you can increase the trust that individuals have to be able to come to appointments and to be able to receive the care that they need and are able to talk about all of their healthcare needs that they have, and that we can reduce the barriers to the receiving that care.
That's lovely. Yeah, that's really lovely. All right, now I'm lost.
Did you want to chat with Dr. Hallwig?
Wait, is he here?
Yeah. Hi. Do you have a minute to chat with Charlie?
Hi, I'm Tara. I think we met him before.
Hi, nice to meet you.
I'm a family doctor from Toronto.
Okay.
And,
This is Dr. Ken Hallwig. He was the site medical lead at Northern Connections for many years, and he still practices there.
The whole premise was to train residents in community to increase the likelihood of those individuals when they graduate deciding to work in northern communities.
Yeah.
Right, and I mean, it's been shown to be the case that if you have some exposure, the berries are less.
Yeah.
But,
Yeah, it's a unique model here in that it's training residents to try and deliver care up north, but also deliver culturally safe care to Indigenous people here in urban areas.
Yeah.
But then at the same time, also there's the service provision aspect of the clinic where you are providing trauma-informed, culturally safe care to people who are Indigenous. And and I think I'm happy to be here to just learn a little bit more about kind of the unique program offerings and the way in which it is a welcoming space for people who are Indigenous. And
this year we have 6 of our residents are Indigenous.
Oh wow. That makes a huge deal. That's a huge deal.
It is. I mean, we're just so, it just makes our hearts bursting, right?
Yeah.
But it's great.
When I asked a few of the team members at Northern Connections what makes their clinic special, I heard a lot of different answers. Respect for traditional practices, the culture built by their very purposeful hiring, that everyone on the team has a voice, no matter what their role.
And,
he was my boss once. I didn't like it. Just saying.
But what really struck me at its core was their focus on relationships, both within the team and with the patients they serve. Today, we're going to spend some time in conversation with one of those team members, a very special team member, Dr. Mandy Buss. Mandy Buss is a family physician at Northern Connections Medical Center, and I asked her if she might introduce herself to us.
Sure. Bonjour, ani kanimet wewete ikwe nadishnakash makwadoram. Name given to me by Crater is Dancing Northern Lights Woman, and I'm of the Bear Clan. My name is Mandy Buss, that my parents gave me. I am from the Red River Settlement in Manitoba, which is where I work, live, and play.
Now, Mandy has many other roles, including as the Indigenous Health Lead for the Department of Family Medicine at the University of Manitoba, where she's also the director of the Indigenous Health Longitudinal Curriculum for the Undergrad Medical Education Department. She sits on the executive of the Postgraduate Truth and Reconciliation Committee as the co-chair of the Curriculum Development and Implementation Working Group at the University of Manitoba and the Indigenous Health Committee for the College of Family Physicians of Canada. And importantly, she's also the former president of the Indigenous Physicians Association of Canada and continues to be involved with the association. Mandy says when she was young, she wanted to be a singer or an actor, but those weren't opportunities afforded to her growing up in a small town, and so she turned her gaze to medicine.
I remember my mom always asked me, like, do you want to go to university and in college? And I basically asked her, I said, which one's harder? She said university. And so I'm like, well, then I'm going to go to university.
She ended up applying to med school, intending to go into psychiatry. But
when it came down to applying, there was a new family med program, the Northern Remote Family Med program, that had entered our CARMs. And I really wanted to work in Northern communities. I wanted to work in Indigenous communities. And so I applied for that program as well as the psychiatry program. And it was really clear to me that the Northern Remote program really valued me as an Indigenous person and that perspective and knowledge I could bring to the program. And I didn't get that same feeling from the other interview. And so, needless to say, I entered into the Northern Remote Family Program, and that was kind of what led me down that stream. And I'm glad I chose that program because I got to spend a lot of time in community through my residency program in Nunavut, Northern Manitoba, various communities.
here's my conversation with Dr. Mandy Buss. So wonderful to hear about your own journey to become a family doctor. I think as I was preparing for this podcast, I was reminded that about 5% of people in Canada are Indigenous, but less than 1% of physicians are Indigenous. And so you really are unique, I think, relative to, our workforce. And I wonder if you could speak to that. And, what was that like for you to be an Indigenous physician? What is it like for you? And why is it important that we have more Indigenous physicians?
Well, here in Manitoba, we actually have 18% of our population is Indigenous. I'm not sure our stats on how many physicians we have, but it's probably still only 1% to 2%. So a very small fraction of our population. And it's growing. Like I think we had 20 last year in our admissions, Indigenous students, which is amazing. And it's growing every year. When I went in, there was usually 1 or 2 per year. That was challenging because there wasn't a lot of support. There wasn't a lot of safe space for us in med school. And we had very different realities than our peers in our class. I think there's a lot more diversity in terms of ethnic, racial backgrounds, but also even socioeconomic backgrounds than there was before. I remember it was like our first or second day of med school. They asked a show of hands how many people had parents that were doctors. And I think it was like 50 to 60%. Then how many had parents that were lawyers or professionals. And it was like a huge number of our class. I would probably say 80%. Most of our Indigenous med students don't have that reality, right? Because it was actually legislated that we weren't allowed to go into med school or law school. If you were First Nations, you had to give up your identity as a First Nations person. You had to leave your communities. And there often wasn't a lot of educational support prior to that to even get to that point. So we don't have those generations after generations within those fields. So last year's grad here in the U of M, there was actually 2 second-generation Indigenous doctors for the first time ever. So 2023, first time having a second generation. And if you think about that was huge. But it's also sad to know that it's not till now that we have a second generation of Indigenous doctors. When there's been generation after generation after generation for other Canadians that have gotten there.
Such an important point. I mean, and I think to me, it also goes back to, what we heard through the Our Care consultations when we spoke to people across the country is principally they wanted to have a workforce that represented the diversity of the communities it serves. And there are many studies that show that health outcomes and care is better if people are receiving care from someone who looks like them, who's from the same cultural background. And it's, of course, also important to note that the Truth and Reconciliation calls to action, one of them relates to increasing the number of Aboriginal health professionals working in the healthcare field. So yeah, a really important piece that we need to get right. And I appreciate your historical context on that. And kudos to you for being the first in your family to be a family doctor. We've, of course, been talking about this history of Canada being on colonized Indigenous lands and the decades, the centuries of erasure, displacement, cruelty, and institutionalized racism that I think is really at the heart of some of the disparity in health outcomes that we see between people who are Indigenous and people who aren't.
Yeah. Health and wellness are complex, right? We have for a really long time talked about health within this kind of biophysical perspective. And that's really important. But when we only talk about it, we don't understand what makes people healthy and well and what leads to biophysical wellness, right? Because it's more than just the body. And I think the impacts that colonization had in terms of for Indigenous people, losing their way of life. So, they lost their ability to practice their ceremonies or their wellness practices, their government practices. They lost their lands and hunting and, things that kept them healthy, picking their medicines, being out on the land, connecting. All those practices actually encompassed all parts of health. So the spiritual health, the physical health, because when you're moving and you're on the land and you're bending, it's good for the joints, it's good for the body. When you're on that land, it's really good for your emotional and mental health. And then when you connect to spirit through that, all those practices that were done contributed to wellness. And through residential schools, the 60 Scoop, day schools, relocation, the TB sanitariums, all those things and ways of being well were disrupted. Kids were taken from families. Like, I can't even imagine what that would do to me if someone just came to my house, my son's First Nations, and just took him away. Like, I think that would destroy me. And that would destroy him too, right? Those things have been going on until the 90s. And now they've just kind of taken a different form. We see those things happening through child apprehensions through CFS. We see food insecurities. We see still lack of traditional foods in communities, and we're seeing higher rates of things like diabetes. So those things relate to that biophysical kind of model, right? We didn't see diabetes in First Nations, Métis, and Inuit people before the 1930s. So sometimes we don't recognize how some of those processes that happened through the colonial process actually led to disease states such as diabetes. And then we know diabetes is also a risk factor for coronary artery disease, heart attack, stroke. So, and those things reduce life expectancy, right? The systemic racism, the access to health in First Nations, Métis, and Inuit communities, we know is much less. So screening for cancer, like all those things, Indigenous people have less access to those things. They're caught later and usually non-reversible by that time. So those things all impact those stats, right? As a family doctor, I think one of the important things is we're often the first line of the healthcare that people interact with. I think that if we can create safe space for people to come, then they're more likely to feel like they can come for that preventative care so that we can churn some of those stats around. I mean, it's not the whole picture, like that's only one piece of, the determinants of health, but I think that it's a starting place. And I think it's where we can work on it in primary care.
Yeah, and I'd love to know more about how do you think we can create that safe space, Mandy?
Well, I think one, you kind of mentioned earlier, having more Indigenous doctors, because I think people feel like they don't have to explain everything when they see someone. They don't have to explain what are the impacts of residential schools, whether it's first, second, or third generation, right? They understand. having more training with other staff that are there so that they understand some of the limitations, the barriers, right? I think having representation of other ways of wellness, like Indigenous ways of wellness. So like elders, knowledge keepers, having space that people can smudge in if they want to, you know, even the way we ask about those things, we can't assume that everybody practices that way, but we should be asking about it. We have to ask about it in a way that's non-judgmental, non-stigmatizing as well. I'd love to see community hosts that, welcome people, help navigate the system, you know.
Yeah, I mean, I think some of this also comes down to ensuring that our spaces, our healthcare spaces, are culturally safe. We heard that in our care, free racism and discrimination. And it goes back to these calls to action from the Truth and Reconciliation Commission that we need to provide cultural competency training for all healthcare professionals, and of course need to increase the number of healthcare professionals that are Indigenous. I actually had a chance to visit Winnipeg a few months ago, and one of the things that stood out to me, I was at a primary care day and there were a number of different presentations, but the presentation actually that stuck with me was from a mobile health clinic that just got started up, I think, in Winnipeg. I think it's still pretty new, but they had this presentation about how it's structured, and it's exactly as you say. It's a structure of there's team members there. Importantly, they're going to patients. They're not asking patients to come to them. So they're really trying to even break down that transportation, geographic barrier, even in an urban setting. They have, an Indigenous social planner as an example of a unique role that they talked about. They talked about also the value of relationships. At the end of the day, we also are working in a cash-strapped system, a system that always seems to not have enough resources. And so it feels hard to provide more time when we're supposed to try and be more efficient. But yeah, I wonder what your thoughts are, in this time of scarcity that it feels like we live in. How is it that we can also simultaneously ensure we do provide the resources to those who need it most?
It's hard sometimes to connect an intervention to distal outcomes. And I'll explain myself. For example, to kind of elaborate on what you said, we at our clinic do a couple outreach clinics. One is a teen clinic and one is to a program that supports people in the downtown core area. These are people that often have lots of trauma, a lot of colonial trauma for the most part, houselessness, all those things. And so we go there as well. And it's not scheduled appointments like a clinic. So I don't see as many people when I go there. I go there, I sit down, I'll have coffee, I talk to people and say, hey, I introduce myself. Do you need to see a primary care physician? And some of them want to go see me, and then we go and talk. Many of them don't have primary care doctors. And so I always offer them if they want to come see me at my clinic. I've had a couple people from those community events have come and seen me in my clinic. It was really hard, though. I remember one person, she said, it was one thing to see me in community. And when we sat in ceremony together, it was another thing to come into a clinic that feels very institutional. And it really brings up a lot of trauma. So I think one of the things we have to think about is how can we provide care in spaces that feel safer? Maybe in spaces that aren't clinical. Like we tend to bring everything and that's got to center around that Western model instead of how can we maybe do things where it's not centered around us, but we're just one piece of it. And that's one thing I like with the outreach clinics is because we're not the center of it. We are just a small part of it. But then you really get to meet people within the community. And it takes a bit more time at first. But, there was a couple times where had I not been there or one of my other doctors been there, the outcome would have been worse. They would have ended up in the emergency, possibly ICU, right? There wouldn't have been that intervention. But it's hard to say, oh, me spending that time there meant that person didn't end up in emerge care. Because a lot of them have also multiple comorbidities, right? Yeah. So they'll probably need emerge services or urgent care for other things anyway. So it's really hard to know that.
I mean, I think what this conversation is highlighting for me is how important it is as we think about improving the primary care system, that we realize that it can't be a one-size-fits-all solution. And in particular, for people who have experienced decades, generations of trauma, we need to take a different approach and meet them where they're at, not just psychologically, but physically. We need to go where they're at and really be embedded in community. And I think be humble to understand that there is a lot we don't know, that we're not coming in with the answers. Hey, it's Tara. I just wanted to pop in with a quick opportunity for you to have your voice heard. Something you hear me talk a lot about on this podcast is the Our Care Standard, a clear outline of what every person in Canada should be able to expect from the primary care system. Now, the standard was shaped by feedback we received from nearly 10,000 people in Canada back in 2022. And now, we want to hear from you. Whether you have a family doctor or not, we want to know, how does your healthcare stack up to the Our Care Standard? It only takes 10 to 15 minutes to share your story. It's completely confidential, and it'll help researchers like me understand what's needed for a stronger and more equitable healthcare system in Canada. And more importantly, it will help us all hold our governments to account to deliver the system we all want and deserve. You can take our survey anytime between now and July 9th. Just head to ourcare.ca/survey or click the link in the show notes of the episode. The Our Care Survey is a research study led by me, Dr. Tara Kiran, at the MAP Centre for Urban Health Solutions at St. Michael's Hospital in partnership with the Canadian Medical Association. All right, back to the episode. You talked about your own clinic, Mandy, and I did have a chance in Winnipeg actually to visit Northern Connections Medical Center where you work. I love that it's this training model that's, supporting people to deliver culturally safe care for Indigenous people in lots of different environments while also providing those services to people in those environments. We've spoken a lot about creating this culturally safe space. And I think sometimes people actually have a hard time recognizing that racism and discrimination, interpersonal racism and discrimination, continues to exist. I'd love to just actually share a clip with you. We spoke with your clinic manager, and she was telling us a story about something that happened to a patient and how the team supports her.
One of our nurses took a patient to the lab, and part of it was the process of them not wanting to accept the person's lab rec because they didn't have a Manitoba health card. A lot of our clients don't. They've lost it, or that's gone to a different address. And so just even just in the process of trying to get a new one is too much overwhelming for them to try to navigate. So we help them with that part. Mm-hmm. But in the meantime, if they have made it to an appointment, and then we want to seize that moment to have whatever care we can, provided any treatment, any diagnostics, whatever, in that moment. And so the staff person went with them to the lab with the requisition to vouch for the person. And there was barriers. They're saying, no, it has to be there. They have to come with their Manitoba health card. So a bit of back and forth, and then finally it was accepted. And then there was also to be I think it was an EKG, And so they were like, no, you can't do that here. You have to go back to register the person at the information reception desk. So the staff person went there, and they're going, no, they need their ID card. And apparently some eye rolling and some nonverbal that was experienced by both the staff and the client as well. And the client commenting to the staff person saying, this always happens, it's okay. Well, it's not okay that this always happens to this person or anyone else. Also saw it through the lens of the staff person, who happened to be an Indigenous herself, and so was experiencing it over again for herself through her clients. And so there's lots of those stories.
Yeah, what's your reaction to that, Mandy?
Sadly, this is a common thing that we experience. And I think two things happen. Either, our patients, they just accept this as their norm in terms of navigating the healthcare system, or they just won't navigate the healthcare system because of it. Not too long ago, a patient came in and was seen by our nurse, and they were assessed being quite sick and needed to be seen in an urgent care setting. They refused to go. They said they did already try to go. Some of the staff saying negative things about them being a First Nations person, and left in one go. And so the nurse, talked to them and said, okay, well, I can send for blood work and an x-ray, and said, can you come back tomorrow? Go get it done right now. Come back tomorrow. When they came back, the nurse came to me and explained the story and was like, I'm actually really worried. They seem dehydrated. I think something's going on. We didn't get everything back, but we did get like some blood work back, and they obviously had an infection going on somewhere in their body, and they needed probably IV antibiotics, IV fluids, and more workup to figure out what was going on. And so they talked to me and asked me if I'd come talk to the patient. And I went into the room and had to just like start off by acknowledging, like, I'm sorry that you heard those things and that was your experience trying to get help. I had to like basically negotiate with him and be like, look, I cannot help you in this clinic right now. You need more help than I can give you at this moment. Luckily, I knew that day when they came, I knew the doc that was on urgent care, someone I had known, went to school with. I'm like, I will call them and personally talk to them and let them know that I need you to be seen there, and that what your experience was, to try to buffer that experience. They agreed to go with that. And, I was able to call and be like, you know what, this was their experience. They left because of this. And then they went back. And as far as I know, they stayed. They ended up getting admitted. They needed admission. So they were really sick. But I had to negotiate with them to just go. And this is what I mean, like when I was talking about earlier, like, because he didn't want to go, had he not come to our clinic, or had I not taken the time and the nurse taken the time to talk to him, acknowledge his experience, help try to buffer his experience, he would have gotten really, really sick. He still would have ended up in the emerge, but the outcomes might have been worse. So I have these experiences quite regularly where I have to try to navigate caring for people in the less than gold standard way because they don't feel safe going into those spaces. It's an uneasy feeling, but I'm like, okay, well, we'll have to do what we can do the best of ability, or I have to convince them, or they just don't go and they don't get the care they need.
Yeah. I mean, I think to me, these stories illustrate how racism and discrimination persist in our healthcare system, how they are a barrier to even going through the front door. One of the things in our care actually that's really stuck with me is something we heard in our Indigenous youth panel in Manitoba very early on from a participant who said that they go to the emergency department expecting to be discriminated against. And I mean, every time I hear that, I feel so awful, because that's the place that people should feel safe to go to, because it's supposed to be the place that you go to when you're most in need. And in fact, so many of them are going to the emergency department because they don't have access to primary care. So, it's just layers of discrimination and barriers on top of one another. And I think the other piece that I think really struck me in the story that Linda, the clinic manager, was speaking about was how it also hurt the person who was the healthcare worker who was Indigenous, because she was being re-traumatized by watching this happen in front of her and not being able to really do a lot about it.
Well, it can be really disempowering, right?
Yeah.
Because I think that for Indigenous people that enter into healthcare, especially when we want to work in our communities, and I think most of us do, because we grow up seeing those gaps, it's not just our job, right? Like it's personal too. It's very personal.
Yeah. And so, I mean, I think, again, this, creating a culturally safe space means recognizing what the space is like right now and the reality of it for many people today. And then I think you've talked about some of the beautiful things you can do. You talked about team members, about team building, about culture.
We had a grant for a while. We had an elder knowledge keeper that was really amazing and helpful. Our patients really appreciated it. And they had a gift that I don't have that they could help my patients with. We also have social worker and physiotherapy and occupational therapy and pharmacy. So they get to use their skills to help patients so that we can work together, so that I can do what I'm trained to do as well. So I think that's helpful. But everybody on that team also has to be culturally safe for those patients so that they come in, they feel welcome in our environment.
Yeah, I mean, I think what I love is I'm hearing, despite the challenges, there are ways that we know we can design the system to support the people who are most at need. And some of that includes creating the time and the space for those people to feel comfortable to share and feel welcomed into a space where they traditionally actually haven't been welcomed. I wanted to play actually a clip of a conversation I had with Dr. Ken Hallweg at the clinic. He talks about the impact that the knowledge keeper and the elder had on patients and on his relationship with patients.
So, I mean, they're a part of the clinical team, right?
Yeah.
So, as equals integrated into the care. So, if I had a patient who is Indigenous, I would, often casually just ask, did you grow up with, traditional practices? Is that something that you're interested in or practice currently? And if so, we do have a knowledge keeper now, and we have a mental health worker. We also have medicines. We have, sage and sweetgrass and to help facilitate your ceremony. And I mean, it was amazing just to see the faces of our patients that people have known like for a decade or more. All of a sudden, I felt like I was seeing them for the first time because there seemed to be this palpable like barrier dropping.
That's so beautiful.
Yeah, I mean, it was amazing. It truly was. So, I mean, we're all just so like we were heartbroken at the end of the funding. Was hoping that WHA would see that they needed to do this. I mean, they have on their website how they're wanting to fulfill the
TRC calls to action.
The calls to action.
Tell me about that having the knowledge keeper and elder at your clinic.
For me, it was so valuable because to me, like I remember when I was, we were talking earlier about being in med school and feeling, very alone and not safe. And then when we finally got a space, I think I was in my second year, and then we had an elder come in. It just changed how I felt in that building. I felt like there was a place I could go that was safe. I could go talk to the elder. I could smudge if I was having a bad day. Just having that warmth. And then when we had that at our clinic, it started feeling like that a little bit. Then we brought on the knowledge keeper, and it was just another thing we could offer patients. And I actually, before we even had the knowledge keeper, I used to have patients all the time ask where they could access elders and knowledge keepers or medicines or things like that. And sometimes I could know community resources, but they're limited. And it's not always open access to everyone, or people can't always get to those places. So I think it really created this space that told our patients that they belong there, that we're actually thinking about what might be their ways of healing outside of the Western biomedical model. I think that creates safety within that. Even though we don't have that anymore, like we're still in conversations with the WRHA.
Winnipeg Regional Health Authority, yes.
Yeah. I'm hopeful in the future we will be able to reintroduce that. I'm still in contact with our knowledge keeper, and she does want to come back to our clinic, which says a lot, I think. Although there's challenges with it. We're not perfect space either. We still got growth to do, but we're trying to get there. I think it's also changed how our staff think about those things, even our students. I think it's had profound impacts that are lasting despite us not having them there in the moment.
Yeah, so impact on patients, but also impact on the service providers, the physicians, the other healthcare workers who are Indigenous. And I think it's worth us, reading out this call to action that really addresses the specific point that you tried to address in your clinic. It says we call upon those who can affect change within the Canadian healthcare system to recognize the value of Aboriginal healing practices and use them in the treatment of Aboriginal patients in collaboration with Aboriginal healers and elders where requested by Aboriginal patients. And I have to say, I think your clinic is the first really that I knew about where this is actually taking place. And so kudos to you for your vision, for making it happen. And I hope that you do get the funding to continue with it. I think just as we wrap up, Mandy, I wonder if there's any last reflections you want to share. This is a podcast of listeners who I think are engaged and interested in improving our primary care system. What would you want to share with them?
One thing I want to add about the elder knowledge keeper in our clinic, because there have been other clinics that have had elders in their clinics. But the one thing that I really wanted to make sure within our clinic, that it wasn't just an elder there for patient care, even though that was a big component of it, but that it's not to be siloed in that way, that the elder knowledge keeper actually need to be embedded within our clinic. So a part of the faculty and team building, a part of the resident feedback and education, a part of, the meetings where we decide how, our harm reduction, our trauma-informed care, and a part of that patient care, so that it's really woven within how we function as a clinic, not just they're in a separate room and they see patients for only that way. Because I think for it to work, it really needs to start being woven into those processes. And I think that's why we have some of that lasting impact. I think for just other listeners in total, and it kind of speaks to that, is when you're trying to do this work, and I hope that people are committed to this work, but when you're starting to think about how can we provide safer primary care, how can we look at our clinic or ourselves, is to not think about one little thing and how into these little pieces, but how does it actually work and function as a whole? Think about the patient experience. How do they walk into the door? What do they see? What do they smell? Right? What are the senses? What do they hear? Who do they see? How are they greeted? How does it flow? When they leave, who do they see as they come through the clinic, and how does that process work? And then when they leave, are they rebooking? Is the continuity? How are they engaging with other people? So kind of think about those things. Think about, what do your staff know? What do they need to know? How do we look at the social determinants of health, and how do we start addressing them even from our kind of micro meso level? And then how do we advocate for those larger system things as a clinic? Because I think if we do that, and if we all do our little pieces, it's going to make bigger impacts in the larger system.
Yeah, I love that. The whole person approach and the whole clinic approach to serve the whole person. Yeah, so thank you, Mandy, for helping show us the light in terms of where it is that we need to go in this space.
Jamie Gwitch for having me.
Primary Focused was created by me, Dr. Tara Kiran, and is made possible by a grant from the St. Michael's Foundation. Miriam Dinesh is our research assistant, Seema Marwaha and Emily Holton are creative advisors, and our producer is Avery Moore-Kloss. If you'd like to read more content from me about Canada's primary care system, join our Substack newsletter at primaryfocus.substack.com or visit our website, primaryfocus.ca. For more information on the Our Care Standard and the public's vision for a better primary care system, visit ourcare.ca. The information shared in this podcast is for educational and informational purposes only. It's not intended as medical advice and should not be used as a substitute for professional medical care, diagnosis, or treatment. Always consult with a qualified healthcare professional before making any medical decisions or changes to your health routine. Views expressed in this podcast are those of the speakers and do not necessarily reflect the views of any organizations I may be affiliated with. Side effects of listening to this podcast may include a strong impulse to help fix the primary care crisis in Canada, a feeling of anger over how many Canadians do not have access to primary care, increased feelings of empathy toward primary care professionals who are just trying to make it work, and intermittent visions of hope that we can find a better way.